I'm totally free to get interrupted as much as you want to. Ask me questions as we go along. If something doesn't make sense, please stop me. I've also been asked from the other room, if you have one of the cobalamin processing disorders, they're actually talking about a remethylation research map across on the other side. So for some of the families, that might be applicable. For most of you, it may not be applicable. Okay, so I have a conflict on this side of the wall that's different than over there. I'm the PI of the Hemashare Therapeutics HST 5040 clinical trial for which Children's National is compensated. I noticed Children's National is compensated. Well, it actually pays for a percentage of my time. Okay, so I'm going to start out by saying, what do we have in the room? So who has PA? All right, who has MMA? Do we have any IVAs out there? No, so we won't spend a lot of time on IVA. GA1. Any GA1s? They're not here yet, so they haven't come back from break. All right, GA1 is cobalamin C's. Okay. All right. So I'm going to start out, and the irony is Mark Corson actually helped me out really a lot this morning. And so I'm going to start out by talking, what is an organic acidemia? He actually already answered that earlier. Why sometimes it's a bit confusing what's included in the group. Because he talked about some stuff, then you're like, why is that here? And then what are the possible sites for therapy? Where can we target if we're talking about PA, MMA, IVA, GA1? And I'm assuming that none of our D2s are here, none of our L2s are here. Yeah, okay, because there's some really rare stuff that typically come to this meeting, and I was told that they didn't register, but if they did, I was going to deal with it. So this is very similar to the slide that Mark showed you, yeah? Yeah? So what is an organic acid? Well, an organic acid is just something that has a carboxylic acid group on it. And the R is carbon. That's an organic acid. Now, there's lots of organic acids out there. And the disorders that we talk about are disorders in which there's a block, an accumulation of a particular organic acid, which got doctors' attention. Now, everybody says, what's the difference between an organic acidemia and an organic aciduria, right? Like we, Oleg and Chuck and I and Arini and all the providers like use those names interchangeably often, or we'll use one thing specific versus the other. What's the difference? So an aciduria is any disorder which accumulates organic acids in excess in the urine. That's it. And acidemia is any disorder which accumulates organic acids in excess in the blood. And ironically, most acidurias are acidemias as well. Historically, we were able to look at urine for organic acids much more effectively than we were able to look at blood. And so you may actually see a migration in the terminology over time. So if you start looking in the 1961 paper versus a paper that's published this year, you will actually see a migration over time because we can actually measure organic acids in the blood much more effectively than we could 10 years ago, 20 years ago, 30 years ago, 40 years ago, 50 years ago. And almost all the metabolic organic acidemias and acidurias are due to an abnormal breakdown of amino acids. Different ones have different amino acids. Now, I like when I talk about therapy to start out by saying, I want you to think of whatever disorder you have as a dam in a river. Why do I say that? Well, so when we think about basic biochemistry, and we all remember this maybe from like high school chemistry. So we have these things, A plus B will lead to product C, right? And if you have a metabolic disorder, it's like blocking A to B producing C. And what happens is you accumulate A, and A leads to F and E, and you're deficient in C. And this is like sticking a dam in front of a river. And you flood upstream and you're deficient downstream. And when we start thinking about, okay, what are the things that I'm going to measure when I identify this? How am I going to treat this particular disorder? This is kind of how the framework, and I use a particular framework. What do we treat? Well, I do reverse avoid catabolism. As I said, Dr. Corson did a great job setting us up. Scavenge, which is suck up the floodwater, whatever the floodwater is, replace that which I'm not making, and make that dam work better. And in this case, poking holes in the dam, replacing the dam, all these things. What have we not been very good at in terms of treating organic acids? We're not very good at treating the complications of organic acidemias. I can do all of these things, especially in the acute phase and a metabolic decompensation, and get everything look better. But what we're not very good at, and what we have not done a very good job of preventing, is some of the complications. So the stroke-like episodes or metabolic encephalopathy, the movement disorders, the learning differences, the eye disease, the cardiomyopathies and arrhythmias, the kidney diseases, the myopathies, the neuropathies, all of those things, we haven't really done a great job. And that's on metabolism. That's also on, we just are starting to figure out what some of these disorders have as long-term complications. And honestly, we're starting to understand some of the physiology. And I'm sure Dr. Venditti will talk a little bit about and Dr. Oleg will talk about what some of the physiology for these disorders. So as I said, this is what I teach every single one of my med students, every single one of my residents, every single one of my fellows, so that we don't miss anything, all right? And I like to picture the dam because I like pictures. And I say, okay, our job is to reverse catabolism, avoid catabolism, and decrease exposure. What do you think that is for your disorder? What is your exposure? Come on. So, well, that's what's actually going to make your catabolism. How about valine, odd chain fatty acids, methionine, isoleucine, threonine, tryptophan, lysine, leucine, right? The amino acids, right? So that's going to be our exposures. That's going to be what puts water into my flood. And then avoid catabolism. This is avoid illness if we can. Treat illness because that's what I've got. This is treat fevers. This is plan for immunizations. This is do not become dehydrated. And then scavenge toxins. So the toxins we usually think of is the acid toxin and the ammonia toxin in this group. There's a few exceptions with a few other disorders. And then replace that which is non-manufactured. We'll talk a little bit about this. And then cofactors. So several of these disorders have cofactors. These are enzymes or vitamins that you add that make the enzyme work better. You're poking holes in that dam. And then research, can I fix the enzyme function? And can I fix the enzyme function by enzyme replacement? Can I fix the enzyme function by gene therapy, by mRNA therapy? And almost all of this is research at this time. What we're really lucky, though, is we have so much research going on right now, right? So Therapeutics 101. So how can I do stuff, right? I can use a small molecule. Most of us are familiar with levocarnitine. I can do enzyme replacement for some of these, maybe not for all. I can use a cofactor or chaperone. And these are almost the cofactors we use. The chaperones we don't use quite as much. But there are some chaperones that we do use in metabolic disease. And the nucleotide therapy, and that's almost always a research-based thing. So let's talk a little bit about the propionate pathway disorders. I'm going to group these together. We all know that MMA is not PA and PA is not MMA, okay? But I find it easier to talk about these disorders together because they're often appropriately or inappropriately added together because they're in the same pathway. So this is the C-vomit pathway. Mark introduced this earlier today. Cholesterol, valine odd-chain fatty acids, methionine, isoleucine, and threonine all get broken down to propionyl-CoA. This gets, by propionyl-CoA carboxylase, it gets further broken down to methylmalonyl-CoA, and finally gets broken down by methylmalonyl-CoA mutase, cobalamin A and cobalamin B, to succinyl-CoA, which is a major component of the Krebs cycle, citric acid cycle, or tricarboxylic acid cycle. Does anyone remember this from high school? I'm watching 1, 2, 4. Basically, it helps us make energy, okay? That's all you care about. All right, so propionic acidemia, and I'm using acidemia here because we can find propionate in the blood, is caused by dysfunction of propionyl-CoA carboxylase, or PCC. It can be encoded by one of two genes, PCCA or PCCB, and oftentimes in the decompensated state can lead to metabolic acidosis. There can be a secondary inhibition of the urea cycle, which is where the ammonia comes from. And then if I'm going to make the diagnosis, I can find elevations in 2-methyl citrate, both in the blood and in the urine, 3-hydroxypropionate, propionyl carnitine, and an elevation of propionyl carnitine to acetyl carnitine. And when I hear propionic acid, the first things I think about long-term complications are eyes and heart. Eyes and heart, okay? Because the brain stuff we see in both. Let's talk about methylmalonic aciduria. There are 3 genes that are 3 enzymes that are associated here. This is methylmalonyl-CoA mutase. I suspect the majority of folks in the room that have MMA are due to mutase. Cobalamin A deficiency and cobalamin B deficiency, encoded by one of 3 genes, MMUT, MMA-A, and MMA-B. No one said geneticists named the genes very excitingly, as you may have noticed. Again, you can have metabolic acidosis and hyperammonemia in a decompensated state. We typically see less metabolic acidosis in MMA in an MMA patient after the neonate period, but that doesn't mean you can't be hyperammonemic and have methylmalonic acid. The major marker that differs here is the elevation of methylmalonic acid. Typically, we measure it in the urine initially and then confirm in the blood. All the other markers are almost the same, except sometimes you can see C4DC, or methylmalonyl carnitine, on the newborn screen. And if somebody has a newborn screen that has C4DC, that gets reported out, and an elevation in C3 and an elevation in C3, C2, I often think, they're likely to have an MMA. And when I hear MMA, I think kidneys. I think kidneys is the long-term complication. And you may say, well, why do you think of those things? These are the things I think of off the top of my head. It is not to say that you can't have any of these things in either of these disorders. So what are some of the long-term complications? So when I think about PA, metabolic encephalopathy, that's the fancy new way to say metabolic stroke-like episodes, okay? It's metabolic encephalopathy. Huh? I don't know. Honestly, I practice, because as some of you may know, I have a stutter. I practiced a lot. Yeah. Anyways, PA movement disorders, this is usually due to the basal ganglia, cardiomyopathy, cardiac arrhythmias, optic atrophy, and myopathies. And you can kind of see why I'm like, okay. And I suspect over there they told you all about the renal dysfunction in your slide. Oleg, did you? Or you haven't gone yet? Because you guys switch places. So you can have renal dysfunction with age. MMA, so metabolic encephalopathies, movement disorders, renal dysfunction. And for most of my MMA patients, this is the big player as they get older. Hearing loss, and ironically, hearing loss can occur acutely with an event, but may also sneak up on people. And this is something I think as parents you have to be very aware of, because if we don't check the hearing, we don't know that the hearing is going. Because hearing loss is something we have a tendency not to notice in ourselves, let alone other people. And I want you to think of some of the older members in your family where you start turning up the TV or talking to them louder, and they don't realize they can't hear. So now think about some of the folks. And finally, myopathies. So how did we figure out what we were going to do with PA and MMA? How do we come to an idea of how are we going to best take care of these patients? I already told you the framework that I like to use, but how do we get as a group and come up with kind of plans about doing this? So 10 years ago, Chuck, 10 years ago, we locked ourselves in a room and said, how do we take care of patients with PA? And Jill, you probably remember, Kathy, you remember being locked in this room. And we went through, we said, how do you do acute management? And this was a little bit literature-based, but mostly expert opinion. And then 4 years later, I got locked in another room with a bunch of Europeans. And the Europeans like data, just FYI. If it's published, it is totally. And we did guidelines as well. And ironically, the European guidelines and our initial guidelines were almost exactly the same. And then 2 years ago, I got locked in another room. And then it became a virtual room. And so this is the first revision for the guidelines for PA and MMA. And as I said, most of those folks are Europeans, so it is the European spelling of acidemia. And what did all these guidelines agree with? Well, they kind of agreed with the way that I like to take care of patients. And I think it's an easy way not to forget a step. So what are the targets for treatment? So where can I fix PA and MMA? These yellow arrows are where all the places we can fix it, all right? Some of which currently have clinical therapies, and some of which don't currently have clinical therapies, and some of which have research therapies. So, but like, if we think about this, what am I supposed to do? I'm supposed to suck up the floodwater, prevent more floodwater from going in, poke holes in the dam, and fill out the stuff that's deficient, okay? So these are all the places I can do something. All right, so let's decrease the toxin load. And I'm using toxins in quotes. Decrease the amount of propionate that I make. And we do this through diet. And yeah, we talked a little bit this morning, this is not so simple because diet is not so simple. It's not just taking things away. It's making sure that there's the right balances. And we also take away the toxins by scavengers, and these are small molecules. And these scavengers can also be nitrogen scavengers. And then research-wise, we're looking for ways we can take away the extra propionate, but we're also looking for ways that we can make the enzyme work better. Now, clinically, we use the cofactors for the enzyme. So PCC is a biotin-responsive enzyme, and you need biotin for it to function. Most people get started on biotin. Few people respond entirely to biotin. MMA, the MUT enzyme, is a cobalamine responsive enzyme. So we give cobalamine, that's B12. Research-wise, well, there's a lot of stuff here. If you talk to the folks out here, how do I make my enzyme work better, right? There's messenger RNA, there's some gene therapy for MUT. I haven't seen anything else that kind of pokes holes. There's some thought about some enzyme replacement. And the replace, well, currently we're replacing into the Krebs cycle, and what we're doing is we're using a lot of Bicitra. And Bicitra has citrate in it, and this allows us to put something into the Krebs cycle. Interestingly, the Krebs cycle is more complicated than what you learned in high school biology. Okay, so specific therapies. So in the acute phase, we're going to try to reverse catabolism, right? Here's our D10 electrolytes at 1.5 maintenance. And there's a discussion about whether you should use intralipid, which is fat. And most people kind of argue it. There's this hold protein for 24 hours, but if you've been vomiting for 24 hours and not tolerating protein, as Dr. Corson says, that you've already held your own protein, right? So if you come into management, you may have already done it all for me. I'm going to scavenge the toxins. And I know most people don't think of levocarnitine as a scavenger, but what does levocarnitine do? What does it do? Well, it helps bind onto the C3, right? So it helps bind on the C3, it helps bind onto the methylmalonyl, and helps you pee it out. So it's a scavenger, it's helping you take out the acid. Now, if your ammonia is incredibly high, you may need ECMO or dialysis. You may also need ECMO or dialysis if your acid load is incredibly high and we can't correct it. Nitrogen scavengers, so these were traditionally used in the urea cycle. We do use them in PA and MMA, and this is to help drop the ammonias. And then cofactor, and we mentioned biotin before. So that's kind of the acute phase. And you can see what I'm doing. I'm saying, okay, how do I deal with this flood water? How do I suck up the extra? How do I prevent more hitting the dam? How do I poke holes into the dam? And then is there something I can do downstream? Chronic, again, this is a diet. And the guidelines all say avoid prolonged fasting, protein restriction with supplemental non-propiogenic amino acids. But the balance there is kind of complicated. And in some cases, you may not even need the non-propiogenic amino acid supplementation because your protein amount is such. We're going to use levocarnitine. We also become deficient in levocarnitine, so I got to prevent that deficiency and scavenge the acid. We might use nitrogen scavengers if ammonia is one of your major problems. And then we're going to screen and do standard therapies for the underlying long-term complications. And perhaps I might replace your liver. And this makes the disease milder, but it actually totally replaces the dam in the liver. You basically changed a liver so that now it has a functional PCC, propionyl-CoA carboxylase. Okay. Therapy for MMA without homocystinuria. So this is not the cobalamine C's, not the cobalamine D's. So we're going to do almost exactly the same thing, and I can read all of this, or I can just highlight the difference. The cofactor for this is cobalamine, and oftentimes we'll use hydroxycobalamine, IM. And if you're in the hospital, we might use IV. We typically don't use the IV outside a hospital. And then chronic, we're going to do the diet stuff. We're going to scavenge with a carnitine. We might use nitrogen scavengers, but less. In those who are B12 responsive, we're going to use hydroxycobalamine to drop your levels. We're going to screen for the underlying complications, and here maybe a renal or liver transplant. Some folks always ask me, well, what about renal transplant alone? What about liver transplant alone? And that's a whole nother discussion that we can have separately. Because renal failure is so common, typically you'll want to do liver plus kidney because most people will have some level of kidney disease before the transplant. And there's some families that'll have a liver alone early with the idea of trying to prevent the kidney disease later. And then there's some older adults where the kidney transplant's the best choice. And hopefully for MMA-PA, soon the ACMG will have some recommendations and a white paper about transplant out. So current therapies that are approved for these disorders: carnitine's approved, biotin's approved, hydroxycobalamine's approved. Are people familiar with carglumic acid? Who's familiar with carglumic acid? I know there's a table out there. Yeah, so carglumic acid is also known as carbaglu. Does that help anybody? So it is a nitrogen scavenge that's specifically approved for acute management for PA and MMA hyperammonemia. Some people will use it as a long-term thing, but it is actually approved. And then I put diet as question mark because it's not really an FDA-regulated drug, but your diet is your medication here. So I would argue that it is. Okay. Now I'm going to move on from PA and MMA. Anybody have any questions at this point? Yeah.
Did you say the
Carboglumic acid, yeah.
is it used for long term? I thought it was only for.
It's only approved for short term, but some people will use it for long term. It's incredibly expensive. Some of my patients have been able to argue with the insurance companies to use it as a long-term medication in the United States to prevent hyperammonemia. Ironically, the use is used acutely and chronically throughout Europe and in the Middle East. And so it is a much commoner disease, a commoner medication to be seen used like in the Middle East as a long-term chronic therapy, in like Italy as a chronic therapy, in sections of Ireland as a chronic therapy. Yet in the US, it's only approved for acute management. How's that for is it confusing enough? All right, other questions? All right. So I'm going to talk about IVA. And I think I see at least one IVA. Anybody else IVA, or do you want me to skip this? Okay. You want to see if he wants to come in? Because this is the IVA section.
I have a question about
The eye disease? Yeah.
for PAs with heart and eye. What exactly is
Oh, it's optic neuropathy. You can see some retinal disease. You can see blindness, both acute and chronic. Mm-hmm. Oh, so cobalamin Cs have a lot of eye issues.
But I mean, when I see a PA, I don't always think eyes.
Yeah,
But
so
I mean, I'm not looking in the back of their eyes either, correct?
yeah, so the optic neuropathy and the optic atrophy that you traditionally are more described within the eye disease than but cobalamin Cs, those are eyes. Those are eyes. Whereas here it's part of how I think MMA PA separate. Now, are you a lumper or are you a splitter? Right? Are you going to be a lumper or are you going to be a splitter? But those are the things, like if I have to push someone to go see their specialists, there's different pushing that I'll do with different diseases. Okay. All right. IVA. Let's talk about IVA. So IVA is an abnormality of isovaleric CoA dehydrogenase, or IVD, and it's part of the leucine pathway. And if we use our model system where we're damming a river and we're flooding upstream and we're deficient downstream, this flood is isovaleric acid. It's isovaleric glycine because it can bind. It's 3-hydroxyisovaleric. And it's isovaleric carnitine, or C5. Oftentimes, people think, IVA is a milder organic acidemia. That is probably not totally true. In the United States, we do have a common mutation that is on the milder side. But when we talk about metabolic disease, whether you're talking about IVA or PA or MMA or GA1 or cobalamin C, there's a continuum. You've got the really, really mild to almost no symptoms. I've got a PA that we don't have on diet, and the only time he actually has been in the hospital is when he broke his arm falling off the jungle gym, all the way to the most severe, and this is the neonatal hyperammonemia metabolic acidosis. The IVAs can be an equally spread out thing. The classic presentation is metabolic acidosis and hyperammonemia. The hyperammonemia, again, is a secondary inhibition of the urea cycle. I think it's important for us to talk about the IVAs, not just within the context of metabolic acidosis and hyperammonemia, but we actually are starting to see renal dysfunction in this cohort as they get older. And this was only identified by a natural history study. It was only identified by the EIMD natural history study. Otherwise, we would have said, I've got one here. It's going to be something else. But when all of a sudden, when you start putting together a bunch of patients with this, you go, this seems to be an unusual high number. And in fact, they went on and demonstrated So what are the targets for therapy for IVA? So we can deal with the leucine, right? We want to decrease leucine. We could scavenge the 3-hydroxy isovaleric. We could go after isovaleric guanidine. We could poke holes into the enzyme so it works better. We can replace downstream. So that's a ketone body. We could replace downstream. Or we could also think about, what am I going to do with acetyl-CoA? Can I make the acetyl-CoA bigger and better? Because this pathway leads to acetyl-CoA, and I'm blocking a pathway into the TCA cycle, Krebs cycle, or citric acid cycle. Now, unfortunately, therapy for IVA has been debated and argued for years about what the correct step. So this is an example. This is the EIMD reference guide that's easily accessible that says these are the things we're supposed to do. I've been promised for 5 years that EIMD was gonna publish some guidelines, and they still have not done so. So Dr. Vockley, who was here earlier, actually published a set of guidelines, and what we're gonna talk about is a little bit of this EIMD and a little bit of Jerry's guidelines. I think Jerry got tired of waiting for the committee to agree on something. So let's talk about therapy for IVA. So we're going to do all the same thing, right? The acute therapy, we're going to reverse catabolism, we're going to decrease exposures, and we're going to scavenge the flood water. So how do we do this here? So this is where these guidelines are not particularly helpful, because all these guidelines currently say is rehydration with calories. Now, what you all know we do is we say, please start D10 with electrolytes at 1.5 maintenance, because we know it's going to reverse catabolism. We also know most pediatricians can do that math. Decrease protein for 24 hours. Well, if you're vomiting for 24 hours, you've done it yourself, but otherwise we can decrease it. And then what are we going to scavenge with? So here we're using levocarnitine as the scavenger, but we're also using this amino acid called glycine, because glycine can help you pee out the isovaleric acid. The chronic management is where a lot of the debates come down. So there is a recommendation to do protein restriction in this disorder, but as I preluded, there's a large number of incredibly mild patients within the United States due to a founder effect. And so consequently, in the US, if you're a milder patient, you're less likely to be protein restricted than if you're a more severe patient. And then you're gonna add levocarnitine and glycine to scavenge. You also wanna make sure you don't become glycine deficient or levocarnitine deficient, because if that's your scavenger, and those are things within your system, and you're pulling it out all the time to pee out the extra isovaleric acid, you can in fact become deficient. And what's approved for IVA? So what's approved for IVA currently is levocarnitine and glycine, although most people have to pay for their glycine out of pocket. And then here again, diet. Now I'm going to take a second, because PA and MMA have a large number of research therapies that are currently in trial. IVA is not as fortunate. And I actually called one of the IVA experts in Europe and said, is there anything coming down the pike? And I'm afraid to say there's really not a lot of new stuff coming down the pike for IVA. So hopefully with the hopeful success of the PA and MMA stuff, people will start picking up the other organic acids. GA1. So I'm going to take a second to do this. There's 2 flavors of GA1, so it makes it incredibly hard when you get newborn screen. There's the low excretors and the high excretors. This is a cerebral organic acid, or so we thought. There is a risk at 3 months to 6 years of developing sudden and chronic white matter abnormalities and acute decompensation with acute onset of movement disorder and striatal damage. This is scary as all can be, and children react differently even with the same thing. We have a set of identical twins. One presented with a movement disorder before they had fever. The other one with the same illness with a fever that started never developed the movement disorder. These are identical twins. So we can't tell you why one person will decompensate versus another. Now, this is the thing that has come to light in more recent time. There's an increased risk for peripheral neuropathy and renal dysfunction in these patients as they get older, so adolescents and adults. And again, natural history is the only way that we found this, because a single institution didn't identify it. What happened is a bunch of people were doing a natural history study and recognized that this was an unusual complication in adults. So we used to say GA1s were out of the woods at like 8 years. They're not out of the woods. There's some other complications they can see over time. It's unclear whether continued therapy with diet makes any difference in the peripheral neuropathy and renal dysfunction. This is a newborn screening disorder, and that's the predominant way in the United States that we identify it, but confirmation can be very difficult with the low excretors, and then the markers or the flood water, C5DC, 3-hydroxyglutaric acid, and glutathionic acid. And here is the target for this particular thing. It's decrease the tryptophan and lysine, go after the glutaric acid, go after the glutyryl-CoA, poke holes into the enzyme, and replace acetyl-CoA. And for GA1, there is not just one set of recommendations. There's a revised set of recommendations, and just in the last and just recently there's a second revision, and currently they're working on the third. So therapies for GA1s. Because decompensation can occur with illness more than any of the others, you have to be aggressive and early. You have to plan for surgery and immunizations. This is where you're going to reverse catabolism with your dextrose plus electrolyte fluids at 1.5 maintenance. You're going to scavenge with carnitines, and you are going to be incredibly aggressive with therapy. This is the one place that I have to walk to the residents and say, you're going to schedule Tylenol alternating ibuprofen every 3 hours, and it's got to be scheduled, and we won't stop it for 48 hours. But we want to see a fever. I'm like, no, we don't. Okay. Chronic sequencing is particularly helpful with this. Individuals are on low lysine diets, plus or minus a metabolic diet with lysine-free, plus or minus low tryptophan formula to up to 6 years. There's some families that'll take it up to 8 years due to some recent reports of slightly older children. And then you're going to scavenge with carnitine, glycine, and if surgery, have a plan. And all that's approved for GA1 is the carnitine and diet. And I don't think we have any sometime organic acids in the room. So there's a bunch of other things that often get looped with the organic acids. The ketogenic, ketolytic organic acids, and this is because they spill organic acids into their urine. This is like HMG-CoA lyase deficiency and beta ketothiolase deficiency. These disorders often are also seen in the fatty acid oxidation groups because they often have hypoglycemia or ketone problems. The cobalamin processing defects because of the elevation in MMA. So some of you are in here, some of you are over there. Maple syrup urine disease, which I always scratched my head until one of my more mature colleagues said, well, of course they have dicarboxylic acids in their urine. So MSUD. And then the methylglutaconic acidureas, these are almost all mitochondrial disorders, but they actually release methylglutaconic in the urine. And this is why it gets pretty complicated. And then I'm going to kind of skip over this because I know lots of people are going to talk about the cobalamin processing defects, which lead to MMA and homocysteine. And I'm going to talk a second about the cobalamin defect complications in this group. I want to highlight that cobalamin C has two types, infantile and adolescent adult. Infantile has eyes and developmental problems, and adults have peripheral neuropathy. There's also two types of cobalamin D. There's a homocystinuria alone and an MMA plus homocystinuria. And then cobalamin X, I think they're next door. So what do you need to do? So what are you going to do? You have the disorder. You are a caregiver for a disorder. So I was telling the folks next door, please, 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 when you present, tell people the name of your disorder. Know what the disease is. And I say that because I don't want to see the chart that says, let's say you have cobalamin C deficiency, saying cobalamin deficiency, because that's B12 deficiency. That's not what you have. You're not deficient in B12. You just can't process it. If you have propionic acidemia, I want you to call it propionic acidemia. If you have maple syrup urine disease, I want you to call it maple syrup urine disease, or as one of our adults calls it, the Lucifer is getting me. It's leucine. It's a leucine disease. Yeah. Okay. Inform and educate your local hospital. So if you aren't near the metabolic center and you have to present to a local place, okay, this might be applicable. It always helps if you tell that local place or tell your local EMS, we have something a little different. Let's talk about how we're going to get me through this ER. Here's my ER letter from my metabolic. And I actually have a family who lives in pretty rural Virginia that went into them, and they're like, when we decompensate, we need D10 normal saline. Can we come up with a plan about how to make D10 normal saline so when we appear, you all don't panic? And so they added to their protocol taking a normal saline bag and adding a bunch of D50 to it. So they let the nurses do that in the ER for this patient only, so they don't have to send off to the pharmacy and wait an hour to 2 hours to get started. So inform your local hospital if you live. An ER letter is what we call it. Dr. Corson called it an emergency protocol with the initiation of the acute management stuff, and preferably a contact number for your local metabolist. I really prefer getting called when you're going to the ER. Well, when my patients are going to the ER, so that I can call the hospital. But let's say you're sitting in the waiting room and you're like, why haven't they taken me back? Right now, I'll be honest, it's challenging because they're taking care of so many acutely ill people, okay? And so if you call me from the ER or your metabolist from the ER and say, you know what, we've been here for 30 minutes and they don't seem to be paying attention, I can call the charge nurse in the ER, or I can call the attending in the ER and say, you got a metabolic patient in the waiting room, right? And say, they're here, this is where they are. I've actually had our staff walk out into the ER and say, we're looking for, fill in the appropriate name, and pull them out of the ER and start triaging them. Now, there was no place to put them once they got to the ER, but at least they had been triaged and they knew where they were, and they actually started fluids in the hallway. So that kind of thing. Plan for holidays, or this is the nice way to say plan for vacations. So if you're traveling, know who the metabolist is there. For those of you who are here, it's me. And one of my partners is on call, and I can text her if you have problems. Inform your metabolic provider if your temperature is greater than 38.5, 101. If you're vomiting, please inform us if you're having surgery. If you're having dental procedures, it really helps if we plan. There's nothing quite like getting called by an anesthesiologist. We have your patient who has, what do we do? It's best if we plan. All right, this is my last part. Okay, research. What is it and why do I care? You all care about research because you have rare disease, right? You have rare disease. You should all care about research. Why should you care? Well, one of the problems or advantages of having rare disease is there's not very many of you with any one disease. So what kinds of research are there? What kinds of comforts do we have? Well, I already talked a little bit about some natural history studies and registries that totally changed the way that we take care of some of these disorders, right? I talked about IVA and we suddenly went, there's some renal dysfunction here we didn't know. Talked about GA1. Almost all the PAMA stuff has led to us identifying more complications than we thought. The hearing loss was actually not in the first set of guidelines. It's actually been added to the second one because we started to say, oh wait, there is a lot more hearing loss here than we thought there was. And what does a natural history or registry do? It records what happens when you have something, okay? clinical trials. So this is clinical trials for drugs. And as you all know, there's 3 phases: phase 1, phase 2, and phase 3. Phase 1 is it safe and what's the dose? Phase 2 is, okay, what's the dose and do we get maybe we get a response? I don't know. And phase 3 is, does it work? Okay? And there's multiple clinical trials out there, and it's best to think about this. And then basic science. So basic science is essential for us to understand the dysfunction, the why, the what, when, how, all those things we don't understand about your disease. Don't let anyone tell you that we understand your organic acid, because we don't. We understand big chunks, and the amount of information we've learned since the early 1960s is enormous, but there's a lot of things we don't know, okay? And basic science becomes the milieu in which new meds are born. So let's talk a little bit about registries. Registries help us advance treatment. For example, this comes out of the EIMD registry. You'll notice this is the phenotypic spectrum of organic acidureas and urea cycles. This is talking about how do people present as a cohort, not how you presented, but how does a whole cohort understand. This is the clinical phenotype. This is where we actually got the extra information about IVA. And then let's talk about roads to rare disease therapy. So I like this. So the basic science is what gives us that eureka moment. And that might be the little research high school student who comes up to me and says, Dr. Chapman, I observed this in the chorial fibroblasts from the PA patients. And I say, I don't know what it is. I don't believe it. Do it again. And she comes back the next time and says, Dr. Chapman, it's there. And I look at it and I think about it and I say, I got a biomarker. I might have an explanation of why this is this and this is this and this is this. Let's repeat it 3 more times. But this is my eureka moment. It might be that patient sitting on the ward that I come see and has an interesting complication. It might be, there's all these kinds of things, but it starts as a eureka moment. And then I say, okay, I've got a candidate, targets, molecules. This is my eureka, and this is how I'm thinking about it. So we're going to screen these things because I think we can make this disorder better. And then I do preclinical, and this is almost always animal studies. And at this point, I start saying, FDA, how do we design a clinical trial? And this is where families and patients are incredibly important. Because, I can design a clinical trial that looks at these things and these things and these things, but unless you tell me what's important, unless you tell the FDA what's important, finding the outcome measures is incredibly complicated. And at that point, I say, okay, we're ready for phase 1 and 2. And is this a safe drug? And what's the dose I'm going to use? And then the next question is phase 3, does it work? And then we get to the post-marketing, the approval and post-marketing. Now, there's a timeline under here. This is almost 25 years. This is almost 25 years. And we need patient help at every single step of the way. If it's help with the natural history, if it's part of the clinical trial, but we need help at every step. We need you to talk to the FDA and say, this is what's important to me about my disease. And if it is, I'm tired of giving shots to my child with cobalamin, or I'm tired of this particular diet, or I don't understand why we have to keep having these metabolic encephalopathy events. All of these things help with approval and help the FDA help us help you. As I said, this is 25 years. Everybody's been talking about the COVID vaccines, and it's like an 18-month thing, and it makes us all look really bad when I put up this number. But remember, there's about 20 years of experience of the messenger RNAs that go in before they talked about the COVID vaccines. And so although we talk about these vaccines being developed and trialed and all of those things in this shortened timeline, please don't forget all that work that they did over the last 20 years to bring those to bear. All right. This is the end. Anybody have any questions? I know that was a lot. Questions?
Does anybody have any questions for Dr. Chapman?
I guess I have a question.
Sure.
For the more rare things that you're seeing in these already rare conditions, how do you get an idea of how common they are in a population and what patients should do to maybe help prevent those complications that might be coming along?
So this is where natural history studies are incredibly big. So there's over 350 PA patients in the EIMD and an additional 400 MMA patients. Now, it's a little different than Chuck's natural history study. So Chuck likes to Chuck, you like to dive deeply and really understand the individual. And those are big, broad population studies. And only when you start looking at 100, 200, 300 patients do you actually identify something that could be very rare. The problem is when you start talking about really rare complications for the underlying disorder, you might be talking about one or two. And trying to figure out what the prevention for that is not quite there. Part because the pathophysiology is not incredibly well understood. We know parts of it, but like the balance of everything, really hard to do. And in part, we can make educated guesses, but know that those are educated guesses. They're not final things. And I'm going to use an example. So the Italians felt that free radical production played a significant role in eye disease. And so they used a drug that is currently in clinical trial for something else to see if they could decrease the amount of eye disease they saw in cohorts. And at a certain point, they could reverse that eye disease with this drug. But if you went beyond a certain point, you could not. All right? But that's a common complication of a rare disorder. But you can see how, like, understanding but they didn't know that there was a breaking point. You didn't know that, like, this is the point of no return. And this is before the point of no return. And that study was done on 6 people. But it became very clear, these 3 and these 3. These 3 didn't respond. These 3 did. And this is where they were in their progression. Does that help you? I'm sure it doesn't help you a lot, but...
I don't think there's a great answer.
Well, unfortunately, like, when you're talking small numbers, you're talking small numbers.
Yeah.
You can't... It is really hard to do a placebo-controlled trial in 1. It is. It's a crossover trial. If you do it in 2, it's still incredibly hard. And so you're using history to tell you what is going to respond and what's not.